Hello, everyone. My name is Rudy Soto, Policy Analyst with the National Council of Urban Indian Health. I'm going to be doing a webinar presentation for you on American Indians and Alaskan Natives in the marketplace and helping people understand what they need to know about the Affordable Care Act. This will be recorded, and we hope that this gets shared with as many people as possible. Today we'll briefly touch on the historical background and the Indian health system and how the Affordable Care Act benefits tribal communities, and then move on to the special protections for American Indians and Alaskan Natives in CMS programs like Medicaid, the Marketplace, and Medicare, special enrollment periods, and the ability to switch plans monthly, cost sharing reductions in zero cost sharing and limited cost sharing at any level plan, depending upon income, the ability to apply for an exemption from the individual shared responsibility payment, and cover the ability to continue to get services from your Indian Health Service, tribal, or urban Indian healthcare provider, even after they have enrolled in private insurance through the marketplace. When discussing the special protections on the marketplace, it's always important to remember that American Indians and Alaskan Natives can continue to receive health care services from the Indian Health Service, tribe, or urban Indian organization, even if they purchase a health care plan on the marketplace. Let's start with a list of acronyms that will be used in the ACA webinar. The definitions are listed so you can become familiar with them. They will be used often in the following slides. There's a special government-to-government relationship between the federal government and federally recognized tribes based on U.S. treaties, laws, Supreme Court cases, executive orders, and the U.S. Constitution. Because of this special relationship between the federal government and the tribes, the Marketplace, Medicaid, and Medicare contain special protections for Indians. There are 566 federally recognized tribes in the U.S. Although tribes are located in 34 states, American Indians and Alaskan Natives reside in every single state. You may see the full list of federally recognized tribes by visiting the Bureau of Indian Affairs Tribal Directory and the list of Alaska Native corporations available from the Alaska Department of Resources. The links to those lists are included on the second to last slide of this presentation. A large portion of American Indian and Alaskan Native consumers access healthcare through providers in the Indian healthcare system, which includes the Indian Health Service, tribes, or tribal organizations, and urban Indian organizations, often referred to as ITUs. There are currently 45 Indian hospitals and over 600 Indian health centers, including urban programs. A large portion of these facilities are managed by tribes. ITUs provide direct care in Indian hospitals and clinics. However, when individuals need health services that cannot be provided in these facilities, they may be eligible to utilize a program to purchase care from public or private providers outside of the Indian healthcare system, known as purchase or referred care. However, the eligibility requirements for purchase or referred care are more strict, and not everyone who is eligible for direct services at an ITU facility qualifies for purchase or referred care. In addition to IHS healthcare in Indian country is provided by various federal agencies, such as supplemental funding provided by the Health Resources Services Administration, or HRSA, or grants from the Substance Abuse and Mental Health Services Administration, or SAMHSA. By enrolling in these programs, American Indians and Alaskan Natives benefit by having greater access to services that may not be provided by local ITUs, and the tribal communities benefit through increased resources to ITUs. But today, we're going to be talking about CMS programs, and it's important to remember that American Indians and Alaska Natives who enroll in CMS programs can continue to receive care from Indian health providers. Medicare and Medicaid services administer several programs that impact Indian health. Medicare and Medicaid were signed into law in 1965. Medicare is the federal health insurance program for people who are 65 or older. Medicare also covers some younger people with disabilities and people with end-stage renal disease, which is permanent kidney failure requiring dialysis or a transplant, sometimes called ESRD. The different parts of Medicare help cover specific services. Part A covers hospital insurance, such as inpatient hospital stays. Part B covers medical insurance, including outpatient care. Part C covers Medicare Advantage plans, which are private health plans offered through contract that cover both Parts A, B, and often prescriptions. And Part D covers prescription drugs. Visit Medicare.gov for more information about how and when to change plans. While the Medicaid program was created in 1965, the Children's Health Insurance Program was signed into law in 1997. Both are joint state federal health programs that help with medical costs for certain low-income children and adults. Medicaid eligibility is different depending on whether the state has chosen to expand its Medicaid program. We'll go into more detail about who is eligible for Medicaid in a few slides. The marketplace is designed to expand access to affordable health care by creating a place where consumers can compare health options. By enrolling in CMS programs, AIs and ANs benefit by having greater access to services that may not be provided by local ITUs, and the tribal communities benefit through increased resources to ITUs. The Affordable Care Act and the permanent reauthorization of the Indian Healthcare Improvement Act makes special improvements for the health of those in Indian country by expanding and creating programs not just in the marketplace, but within the Indian health system, such as loan repayment and recruitment programs for health professionals. Healthcare services for American Indians and Alaska Natives is a key component of the federal government's trust responsibility. Updating and permanently reauthorizing the Indian Healthcare Improvement Act helps to fulfill this responsibility. The law also offers American Indians and Alaska Natives more options for health insurance while they can continue to receive health care through Indian health care providers. Definition of American Indian and Alaska Native. Now we're going to go over a few terms that will be important as we discuss the CMS programs and Indian protections. First, it's important to understand the definition of American Indian and Alaska Native is different for purposes of the U.S. Census, eligibility for IHS services, special benefits and protections under Medicaid, CHIP, and for the marketplace. In the marketplace, the definition of American Indian and Alaska Native only includes members of federally recognized tribes or Alaska Native shareholders. But the definition of American Indian and Alaska Native in the Medicaid and CHIP programs include members as well as persons of Indian descent. This definition is consistent with the IHS criteria for eligibility to receive health services. Although there is a big focus on the health insurance marketplace, it's important to remember the special protections in Medicaid and CHIP that also help increase access to health care for American Indians and Alaska Natives. The Affordable Care Act also created Medicaid Expansion, which not all states have elected to do, but even if your state has not expanded Medicaid, protections created in the American Recovery and Reinvestment Act, or ARA, still apply. These protections include: 1. Most Indian income won't be counted when determining eligibility based on income for Medicaid and CHIP programs. No cost sharing for any service under Medicaid for individuals who have used ITUs. 3. Protection of monies and property derived from Indian resources from recovery by the state of individuals who receive Medicaid long-term care services. 4. AN enrolled in managed care in Medicaid or CHIP can go to an Indian health provider even if the provider is not in the network, and the provider must be paid their customary rate for those services. 5. States must seek advice from ITUs before submitting changes to their programs that may have an impact on Indians or Indian health programs, and states must consult with federally recognized tribes before submitting Medicaid/CHIP waiver requests. Additional benefits for Indians and Indian health providers. 1. States are reimbursed 100% for Medicaid services through IHS and Tribal 638 facilities and do not have to pay a share of the cost of care like they do for other individuals. 2. There's no cost sharing allowed for AIs and ANs and CHIP. 3. Indian health facilities are not subject to local licensure by the state, but must meet licensing standards, and health professionals must be licensed and in good standing in at least one state. For purposes of the marketplace, an AIN is limited to members of a federally recognized tribe or ANCSA shareholders. There are several protections in the marketplace. 1. Special enrollment periods and the ability to switch plans monthly. 2. Cost sharing reductions and zero cost sharing and limited cost sharing at any level plan depending upon income. 3. Ability to apply for an exemption from the individual shared responsibility payment. Urbans are often asked many typical questions which generally refer to what type of ID can be shown to prove you're eligible to receive IHS services as an AI or AN. You're deemed eligible for IHS services by the ITU facility. Stop.
Sorry, start the page back over.
Okay.
Whenever you're ready, man.
Okay. There are common urban Indian questions regarding ACA. One typical question that is often raised is what ID can be shown to prove you're eligible to receive IHS services as an AN. When you're deemed eligible for IHS services by an ITU facility, they can print an RPMS letter. Oh man, almost got through it too.
If you need to take a break, man, go fill up your water.
Yeah,
So for sure.
I have a sore throat, so. So I can start again.
Mm-hmm.
There are common questions asked for urban Indians. Urban Indians are affected by the Affordable Care Act as well. And common question that's asked is about what type of ID can be shown to prove eligibility to receive IHS services as an AI. And when they're deemed eligible for IHS services by an ITU facility, they can print an RPMS letter of eligibility and provide you with your application for exemption. If you do not have documentation of your enrollment in a federally recognized tribe, what are your options to receive the provisions? When many AIs and ANs living in urban areas do not have the necessary documentation, oh man, I messed this one up too. Even though each plan level must cover the same set of minimum essential health benefits, the value of those benefits will vary across 4 metallic levels: the bronze, silver, gold, and platinum levels. This means the amount of cost sharing required will differ in those tiers. For example, bronze plans will have the least generous coverage with more out-of-pocket costs for enrollees, and platinum plans will have the most generous benefits. However, these plans might be the best choice for federally recognized tribal members because you do not have any cost sharing for essential health benefits and may qualify for those premium tax credits as mentioned earlier. What this really means is that you should use the tools provided in your marketplace to explore the options and make sure that your local clinic or provider is a part of the network. The first step in getting health coverage is submitting an application. You can apply online at healthcare.gov, by phone, through mail, or in person. You'll hear the application referred to as a streamlined application, which means it allows you to apply for either the marketplace or Medicaid and CHIP programs at the same time. It's also used to calculate advanced payments of the premium tax credit and cost sharing reductions to help pay for coverage purchased through the marketplace. Once you submit an application to the marketplace, your application is verified by a data services hub between the Social Security Administration, the IRS, Homeland Security, and other approved data sources for verification. For American Indians and Alaska Natives utilizing cost sharing reductions or special enrollment periods, verification of tribal membership is required and must be submitted within 90 days of application. If asked for your household income on the application, this will help determine which CMS programs you're eligible for. You'll see 100% FPL or 400% FPL in several different places throughout this presentation, outreach materials, and on healthcare.gov. These numbers are based on the national federal poverty level as determined annually by the federal government. Eligibility for many programs is based on percentage of the federal poverty level and where your income falls on that scale. For example, if you have a family of 3 and your household income is below $27,310 or 138% of the federally poverty level, and you may be eligible for Medicaid. Or if you're a member of a federally recognized tribe or an Alaska Native shareholder living alone with a household income of less than $35,010, you qualify for a zero-cost sharing plan on the marketplace. We'll get into more detail about zero-cost sharing plans later on in the presentation. Keep in mind that Medicaid uses the current year's FPL numbers, while the marketplace bases their income determinations on last year's. So if you apply for Medicaid in 2015, you'll need to check with your state for the most up-to-date federal poverty levels, or visit www.healthcare.gov/glossary-poverty-level-FPL/. In order to be eligible for cost-sharing reductions and monthly special enrollment periods, American Indians and Alaska Natives must demonstrate membership in a federally recognized tribe or Alaska Native corporation, or regional or village. On the online application, there's a drop-down list of federally recognized Indian tribes and Alaska Native corporations. At this time, there are no approved electronic data sources available to the marketplace to support tribal verification. The marketplace accepts documentation issued by a federally recognized tribe or Alaska Native shareholder status, demonstrating membership or shareholder status. To take advantage of the cost-sharing reductions or special enrollment periods, verification of tribal membership is required and must be submitted within 90 days of application. You can upload your tribal documents or submit copies by mail. After your application is verified, your eligibility is determined. If you're eligible for Medicaid or CHIP, you will be redirected to your state Medicaid program. If you're eligible to enroll in a qualified health plan on the marketplace, you will also find out if you are eligible for the premium tax credit and the cost-sharing reductions. Remember, tribal members can change plans monthly without waiting for the open enrollment period. After you apply using the streamlined application, you'll be directed to either your state's Medicaid or CHIP program or the health insurance marketplace, depending on your income and other information you included on your application. First, we'll talk about Medicaid and CHIP. It's important to understand the Medicaid and CHIP program and its protections for American Indians and Alaska Natives. If you don't qualify for Medicaid or CHIP, you may qualify for health insurance on the marketplace. Every state is required to cover certain groups of people. These are considered the mandatory categorically needy groups that are required by statute and include children and families, pregnant women, and disabled and aged peoples. States must provide the full range of Medicaid services to elderly, disabled, pregnant women, and children covered by early periodic screening, diagnostic, and treatment. States may also determine additional benefits and additional groups, including the new Medicaid Expansion group. The Affordable Care Act expanded the Medicaid program to include childless adults, but the United States Supreme Court decision allowed states to choose whether to expand their Medicaid programs. The slide shows all the different categories included in Medicaid Expansion. This map shows the current status of state Medicaid expansion decisions. These special protections are often referred to as the ARRA protections because they are a result of the American Recovery and Reinvestment Act of 2009. We often discuss these protections when we talk about the Affordable Care Act, because if you don't qualify for health insurance on the marketplace, you may be eligible for Medicaid coverage, even though the protections are part of the ACA. First, Indians enrolled in Medicaid or CHIP do not have to pay premiums or enrollment fees. Second, if they receive care from an Indian healthcare provider or or through a referral to a non-Indian provider, they do not have to pay any cost sharing, such as deductibles, co-insurance, or copays. And finally, certain types of Indian income and resources are not counted when determining Medicaid or CHIP eligibility, which are listed here. If you don't qualify for Medicaid or CHIP, you may be eligible to purchase a qualified health plan on the marketplace. The Affordable Care Act provides American Indians and Alaska Natives with special protections in the marketplace. We've been referencing the special protections for American Indians and Alaska Natives in the marketplace. Let's take a closer look at each special protection, starting with special enrollment periods, or SEPs. American Indians and Alaska Natives qualify for SEPs, which means they're eligible to change health plans once a month and not limited to changing plans during open enrollment like other consumers. Check with your state's website for more information about how they process SEPs for AIs and ANs. Even though American Indians and Alaska Natives can change plans once a month anytime during the year, you should still be aware of the potential coverage gap that can happen when switching plans. This is best illustrated by going through an example. If you change plans on May 15th, your current coverage will continue through May 31st, and your new coverage will begin June 1st, meaning you won't have any day of the month without coverage, also known as a coverage gap. However, if you change plans on May 16th, your current coverage will expire on May 31st, but your new coverage might not take effect until July 1st, resulting in a 30-day coverage gap. Either way, the best way to avoid a coverage gap is to consult with your current plan and the plan you want to. Natives can change plans once a month anytime during the year. You still should be aware of the potential coverage gap that can happen when switching plans. This is best illustrated by going through an example. If you change your plans on May 15th, your current coverage will continue through May 31st, and your new coverage will begin June 1st, meaning you won't have any day of the month without coverage, also known as a coverage gap. However, if you change plans on May 16th, your current coverage will expire on May 31st, but your new coverage might not take effect until July 1st, resulting in a 30-day coverage gap. Either way, the best way to avoid a coverage gap is to consult with your current plan and the plan you want to enroll in about the best process for changing plans to avoid coverage gaps. The next special protection is cost sharing reductions, which includes copays, coinsurance, deductibles, and other similar charges. These special rules apply to American Indians and Alaska Natives enrolled in qualified health plans receiving essential health benefits and are based on income. There are two types of plan variations that provide cost sharing reductions for American Indians and Alaska Natives: zero cost sharing and limited cost sharing. AIs, ANs with income at or below 300% of FPL can enroll in a zero cost sharing plan, which means no copays, deductibles, or coinsurance when receiving care from Indian health care providers or when receiving essential health benefits through a QHP. In addition, there is no need for a referral from an ITU provider. The next special protection is cost sharing reductions, which includes copays, coinsurance, deductibles, and other similar charges. These special rules apply to American Indians and Alaska Natives enrolled in qualified health plans, receiving essential health benefits, and are based on income. There are two types of plan variations that provide cost-sharing reductions for American Indians and Alaska Natives: zero cost-sharing and limited cost-sharing. ANs with income at or below 300% of FPL can enroll in a zero cost-sharing plan, which means no copays, deductibles, or coinsurance when receiving care from Indian healthcare providers or when receiving essential health benefits through a QHP. In addition, there is no need for a referral from an ITU provider when receiving EHBs through the QHP. In 2014, 300% FPL is above single consumer household income of $35,010 or less. For consumers in Alaska, it's $43,763. Two-person family household income of $47,190 or less. For consumers in Alaska, $58,988. A three-person family household income of $59,370. For consumers in Alaska, $74,213. Refer to the chart on the FPL slide or the handout for levels for your family. ANs with income above 300% FPL can enroll in a limited cost sharing plan, which means no copays, deductibles, or coinsurance when receiving care from Indian healthcare providers or when receiving EHBs through a QHP. We'll need a referral from an ITU provider to avoid cost sharing when receiving EHBs through a QHP. In 2014, 300% FPL is above a single consumer household income. ANs with income above 300% FPL can enroll in a limited cost sharing plan, which means no copays, deductibles, or coinsurance when receiving care from Indian healthcare providers or when receiving EHBs through a QHP. We'll need a referral from an ITU provider to avoid cost sharing when receiving EHBs through a QHP. In 2014, 300% FPL is above a single consumer household income of $35,010 or less. For consumers in Alaska, $43,763. A two-person family household income of $47,190 or less. For consumers in Alaska, $58,988. In 2014, 300% FPL is above a single consumer household income of $35,010 or less. A two-person family household income of $47,190 or less. A three-person family household income of $59,370. Refer to the chart on the FPL slide or the handout for levels for your family. Limits are between 100% FPL and 400% FPL. If your income is below 100% FPL, you do not qualify for APTC. There's an outstanding issue as to whether AIs and ANs with income below 100% FPL residing in states not expanding Medicaid can qualify for cost sharing reductions. Current regulations do not allow cost-sharing reductions unless you qualify for APTCs, even though there is a special rule for Indians prohibiting cost-sharing for those with incomes at or 300% FPL. This issue is currently under review. If you qualify for APTCs, your premiums could be very low. Please take advantage of the NCUIH calculator to get an estimate of your monthly premiums. It is also possible for your tribe to pay for your premium through a tribal premium sponsorship program. Please contact your tribe to see if they are participating in this program. Insurance lingo can get tricky, but it's not impossible to become familiar with the basics. The next two slides list basic health insurance terms and their definitions. Let's look over 8 basic insurance terms that will be used in today's discussion. And just remember, learning the basic terminology can help in preventing confusion, loss of money, or an unwanted policy. It's important to always review your summary of benefits before you purchase a plan. Make sure you are buying the correct policy. There have been errors with plans that are on the marketplace, so always be sure to check before you buy. Tribal members and CSA shareholders, descendants, and other Indians eligible for services from an ITU may qualify for an exemption from the shared responsibility payment. There are 2 ways to apply for the Indian exemption. Apply to the marketplace for an exemption from the tax penalty through the mail. You must still submit tribal documentation. You'll receive an exemption certification number and can report the same number on your tax return every year. Or 2, indicate the There are 2 ways to apply for the Indian exemption. First is to apply to the marketplace for an exemption from the tax penalty through the mail and must still submit tribal documentation. You will receive an exemption certification number. You can report the same number on your tax return every year. And second is to indicate that qualify for the Indian exemption when you file your 2014 federal tax return. You must be able to produce tribal documentation. Remember, even if you get an exemption, you can still enroll in a qualified health plan on the marketplace. The Affordable Care Act has positive impacts on Medicare benefits and ensures your Medicare coverage is protected. Under the law, your existing Medicare coverage benefits can't be reduced or taken away. You will not need to change coverage or enroll in the marketplace because Medicare Parts A and C are considered minimum essential coverage, but Parts B or D alone without Part A or C does not meet the minimum essential coverage requirement, meaning you would need to get additional health coverage to avoid paying a shared responsibility payment. But the law improves Medicare in a few key ways. First, you may get cheaper prescription drugs. If you're in the donut hole, you will receive a 50% discount when buying brand name prescription automatically when you fill your prescription. You don't have to do anything to get it. American Indians and Alaska Natives receiving prescriptions from ITU pharmacies won't be charged for the cost of the drugs. However, the cost of the prescription will count as out-of-pocket costs, which will help get you out of the coverage gap or donut hole. The Affordable Care Act has positive impacts on Medicare benefits and ensures that your Medicare coverage is protected. Under the law, your existing Medicare coverage benefits can't be reduced or taken away. You will not need to change coverage or enroll in the marketplace because Medicare Parts A and C are considered minimum essential coverage. But Parts B or D alone, without Part A or C, does not meet the minimum essential coverage requirement, meaning you would need to get additional health coverage to avoid paying a shared responsibility payment. But the law improves Medicare in a few key ways. First, you may get cheaper prescription drugs. If you're in the donut hole, you will receive a 50% discount when buying brand name prescription automatically when you fill your prescription. You don't have to do anything to get it. American Indians and Alaskan Natives receiving prescriptions from ITU pharmacies won't be charged for the cost of drugs. However, the cost of the prescription will count as out-of-pocket costs, which will help get you out of the coverage gap or donut hole. Second, you get free preventative services. Medicare now covers preventative services and annual wellness visits without you having to pay a copay or deductible. Second, you get free preventative services. Medicare now covers certain preventative services and annual wellness visits without you having to pay a copay or deductible. Third, your doctors are supported to better coordinate your care. They are working to get you the care you need at the time you need it and provide you the highest quality care possible. Finally, the law fights fraud and strengthens Medicare. The Affordable Care Act builds on efforts to combat fraud and abuse in Medicare. These efforts are saving billions of dollars in money that was being stolen from the program and returning those dollars to the Medicare trust funds. Here are some important points to remember from this presentation. The federal government has a responsibility to provide members of federally recognized tribes with health care. Using non-tribal healthcare resources can increase the resources available to others in your tribal community. Eligible AIs and ANs have certain protections and exemptions under Medicaid CHIP in the marketplace. Whether an AI, AN enrolls in Medicaid, CHIP, or the marketplace or applies for an exemption, the AI, AN can continue to get services from an ITU at no cost to the individual. We know you may have questions after this presentation. This is a list of websites that have valuable information. We know you may have questions after this presentation. This is a list of websites that have valuable information. In addition, you can join the bi-weekly IHS Q&A call for Affordable Care Act questions. Calls are every other Tuesday. You can email acainformation@ihs.gov for more information about the calls. You can also join the weekly Assisters webinar on Fridays from 2 to 3 Eastern Time. You can also join the weekly Assisters webinar on Fridays from 2 to 3 p.m. Eastern Time. You can register for these calls at https://go-to. You can also join the weekly Assisters webinar on Fridays from 2 p.m. to 3 p.m. Eastern Time. And you can register for these calls at the link on this slide. These resources will help you stay up to date and stay involved because there are frequent changes to these policies to improve the health of Indian country. Thank you.
All right.
I'll definitely